One. What's going on, everybody? We're back with the Pain Free Performance Podcast. My name is David Ote, and we are back with our Director of Rehabilitative Services. No longer Slender Man. Now he's thick and swole and lifting weights like it's nobody's business. Dr. Justin Farnsworth. Justin, what's going on, man?
Dude, what's going on is I have gained 9 pounds in the last fucking month. There's something to be said for finishing your meals, Tim Danchek.
That's
something
right.
Absolutely to be said for finishing your meals.
Listen,
it's a good time to be alive.
It's a great time to be alive. The problem is, so here's the thing for Tim. It's not necessarily that he's not finishing his meals. Like, he will finish his meals every so often. But when you live on the acreage that he lives on and you need to walk about a quarter mile for clean water to bring it back, this is just my assumption of his lifestyle, then yeah, you're probably going to start to lose a little weight in that. That's why, he's getting outlifted by his son right now. No big deal.
It's true. Well, and you can't order the kids' meal. At some point, if you're not finishing the kids' meal, that's going to be a problem.
If you want to look like a kid, you order the kids' meal, right? No more chicken nuggies, none of that nonsense. But right now, there's a little group hangout in the Myrtle Beach between the Gunn twins, Danchek and Taylor, and then John and Lala. Honestly, I feel bad for Lala.
I really do too. But I will say it was nice that Tim Danchek found a stand-in for all of his pictures. This new rugged-looking guy that actually has biceps and shoulders. I'm very happy that Tim found someone that looked just like him that he could afford to stand in for all of his pictures.
It's really amazing what Photoshop can do for you. It really is.
Life-changing.
Exactly. So listen, thanks for coming on. I wanted to talk to you specifically about pain. Not because you're a pain in the ass. Well, you are, but not because you're a pain in the ass, but mainly because you've written on pain for the PPSC site. I know you gave an awesome lecture on pain science within the masters. And I think it's just one of these areas that we don't have enough information on as coaches. We know that pain exists. We don't understand the tie between of those areas of what it really means when it comes to getting someone over that threshold. So to start it off, can you give everyone a nice bird's eye view of what pain is, and then kind of what your initial inquiries are with somebody when they are in the presence of some sort of pain within their training?
Yeah, 100%. So pain, the first thing about pain, man, pain is such a hard topic. It's such a thing that it's understood, but it's not understood well, even in the medical community, which it kind of makes sense if you look at how many people we have in chronic pain, if we look at people that are getting phantom limb pain, all these different aspects of pain that still exist. It's a hard thing for us to manage. But the funny thing about pain, pain has been just recently redescribed by the people, the Pain Society of the entire world, basically. So the International Association for the Study of Pain, which is the IASP, actually updated their definition on pain in 2020. And when it comes to pain and the actual true definition of what it is, it's essentially an unpleasant sensory and emotional experience that's associated with potential or actual tissue damage. And I don't like to get too nerdy, but I think when it comes to pain, you kind of have to get a little bit of nerdiness going. Diving into what that actually means. First of all, it's unpleasant sensory, but there's also that emotional aspect to it. And probably we get a little bit farther into this, we'll talk about, there's certain populations that experience more pain than others, even though the sensation is the same. So we know that signal of pain gets sent to multiple different brain areas and can be influenced by your prior experience with that thing. Can be experienced with hey, I'm in the middle of combat right now and I've got 3 bullets in me, but I'm so ready to rock and roll that if I don't go faster, I'm going to die. There are things that kind of help blunt pain a little bit as well. And the other thing is pain is associated with potential or actual tissue damage. So there's this idea that if I'm hurting, I'm breaking something. And I think we need to remodel how we phrase that to people with the understanding that pain does not always equal harm. Maybe sometimes it does. Fuck, if I fell down the stairs and broke my leg, that's going to fucking hurt. That doesn't mean that I didn't hurt something. But when it comes to people, especially that have had chronic pain points, understanding pain does not always equal harm for that person. I forget which class I took when I was taking this, but I remember someone put it really elegantly, helping people understand that pain is a normal part of the human experience. If you're not experiencing some sort of pain, you're probably dead, like as blunt as that is. Understanding that pain is certainly a normal part of what we do as humans, and just rephrasing that from a mental aspect to get people to understand it a little bit better, I think is huge. Now, when it comes to how I would deal with pain, and again, we're going to make this distinction. I am fortunate enough to have a clinical license, so I will treat pain because that's in my clinical license in my practice, right? Whereas if I was not a clinician, pain isn't something I'm going to treat directly. I'm not going to diagnose it directly, but I'm sure as hell going to be working with someone who's in pain. And as a strength coach or as a personal trainer, I definitely have some tools in my toolbox that can help work around that pain point for that person to help them train pain-free. So again, I always think it's important to make that distinction, because I think sometimes in the fitness world, we get a little hung up where someone is in pain and therefore we maybe feel a little bit hesitant to work with them. But then there is the other end of the spectrum where it's just you're in pain, just suck it up, we're going to work anyway, which isn't necessarily appropriate either. So when it comes to understanding someone's pain point or their pain complaint, the things as a clinician I'll always ask is the basics, like what pisses this thing off? What consistently makes it worse? I don't really care about the every now and thens. I want to know every time I do A, this is going to hurt, because that's going to be important. That's going to tell us about the aggravation points. And then I also want to know the easing points. What do you do that makes it feel better? It's funny, a lot of times in a clinical world, especially if you just listen to the person in front of you, they're more times than not going to almost tell you how you're going to help them fix themselves. If you just listen to what they have to say, oh, this thing hurts, this thing feels good. Well, we're going to dive down the feel good pathway for a little bit, because we want to remove some of that alarm or that pain signal to allow you to feel better. So now we can actually work out.
Yeah, man. I going back to the beginning, I think it's so important that you mentioned the definition for what pain is, because so many people see it as a negative thing all the time when it's really just a cognitive red flag, right? It's a sensory response. But I love the redefinition that they came out with last year of it being also attached to an emotional response, because it is very important to attach what someone has been through as being a potential early predictor of eliciting a certain feeling within yourself of what you've been through, right? It's no different from if you've been bitten by a dog when you were a kid, or if you say you hurt your knee. I think that we see that the most is like people that hurt their knee and they think they have knee pain all the time when they may not have. It may not be something damaging for the knee pain, but because they think it's the bad knee still, it's always going to be the bad knee until you mentally shift that in your brain. So that's such an important thing, especially when it comes down to it, because I think as a coach, you need to better manage that situation for your client. If your client is saying that something is bothering them, you can't neglect it and say, well, it doesn't seem like it's bothering you or you're doing just fine. You need to respect and digest that information, but you need to find other ways to navigate through that to potentially alleviate some of that emotional response that somebody has. Like we see that with single leg type activities where just placing a finger on the wall will revolutionize someone's ability to balance and reduce, as I call it, positional anxiety. But if we're doing that, we need to be able to implement that type of stuff. So what I would say for you is being a licensed physical therapist, but also being a trainer and coach at heart, what really is the distinguishing line for a trainer on where they can't cross it when it comes to having somebody come in with pain? What are the areas that they can manage, and what are the areas that is outside of their scope that they really shouldn't?
Yeah, so it's interesting. So in the clinical world, we could really dive into the weeds on there are certain avatars of people that I actually want to experience a little bit more pain. So for example, tendinopathies, okay? If you look at some of Joe Kirk's research, when someone has a tendinopathy, we need to load the shit out of that. And we actually expect them to have maybe a 6 or a 7 out of 10 pain. And the idea is we're rebuilding that tendon, right? But again, that's diving into the weeds of different potential medical issues. And being able to go different ways about it, what's appropriate. When it comes to the strength coach aspect, when it comes to the personal trainer aspect, I think the really big pieces, number one, training through a pain point will never make that pain point better. That will never, ever make that pain point better regardless. So we really should never have anyone that experiences pain with what we're doing with them. They may walk in with pain and that pain may stay exactly the same through our session. And I would call that a successful session. I really would, because we're allowing them to work out, to exercise, to express physicality, which gets them more than just the physical. It gets them the hormonal, the psychological, the emotional aspects of training. But we were able to do that without actually turning the volume up on their pain, which means we did not make them any worse. And in fact, we probably helped them because they're actually expressing physicality. They're going to get stronger. But if you've got someone walking into your facility who walks in and is at a baseline 4 out of 10 at all times, just living life, and you decide to throw a bar on their back and you're going to go ahead and do some barbell back squats, and now their back pain that was a 4 is now a 7, that is inappropriate. And typically at that point, your session's also over. So understanding that when you kind of piss something off, it tends to stay pissed off in that session is really important, because now we start talking about, well, appropriate warm-up selection, appropriately maybe using the foam roller and some other modulation techniques like breathing. Like, we know deep breathing has a very positive pain relieving effect. So why don't we throw that into our warm-up to help bring that person down, to allow us to get something done in that session? It's interesting. I've had a couple of patients, and they're usually more the chronic pain type patient, which again, I hate labels, but chronic pain really just means pain more than 3 months. That's what chronic pain is defined as. The people that come in that have some chronic pain points, and we actually start our sessions with breathing. We do 3 to 5 minutes of box breathing, or whatever word you want to call it, parasympathetic breathing, crocodile breathing, some sort of breathing pattern. And I've actually had people who walked in at an 8 out of 10, their own kind of subjective self-perceived pain point, and I've taken them to 50% less. We've been at a 3 or a 4, which what happened was it allowed us to actually get something meaningful done, rather than me having to, as David O'Tay loves to say it, rub their ass and put the little blue gooey gel on their low back because their pain was still present. Yeah. So I think from a trainer perspective, I think understanding that more times than not, if someone comes in pain and you're not making it worse, perfect. If someone comes in pain and you're actually able to help it a little bit, not because we're directly treating it, but because we're smart, we know how to do certain things. We know how to foam roll. We know how to maybe do some mobility work that maybe will feel good and give us an opportunity to work out. Like, we have those aspects. So we even have an opportunity to make that person feel a little bit better holistically, which again, I think is really huge. But big takeaway, if you're doing a thing and that thing makes their pain go up, stop doing that thing. Like, it's just not going to go away by training through it.
Yeah, 100%. And I think that when it comes to identifying what's most appropriate for somebody, a lot of it comes down to the programming aspect as well. Like, am I choosing the appropriate exercises that are going to put them in a position to load the body in the right way where they may not elicit the same pain? Some people may feel like in a back squat that the front side of their knee is going to explode. And I don't know why, but for whatever reason, they feel like it. But if you do a goblet squat or a front squat or a different variation, maybe safety bar, they don't feel that same sensation. Maybe you switch to box squats instead of free moving squats. Maybe that alleviates that. So we have to take into consideration that environment will also breed whether somebody gets that sensory response to feel pain or not as well. It's not just a matter of what's in the body is doing its job. The cognitive aspect of how you perceive the situation can also make you feel more threatened or less threatened. And that's ultimately what the signal is telling you to do. So if it's not a pain response from a damaged tissue area, but it's a potential risk, then your body will be more likely to set off the alarm if you're in potentially risky scenarios deemed by your brain. So we have to be very clear on the fact that we don't understand very much about the brain. Like, we know a lot about it, and it's still very, very little in relation to the complexity of what happens from the cognitive standpoint. But as a coach, I think the best cognitive decision you can make is understanding when you have the wherewithal or the education to help somebody within a certain scenario, and when you don't. You're not going to be able to fix everything. You're not going to be able to troubleshoot everything. If somebody feels a certain level of pain, you have to be confident and comfortable enough that you're going to outsource them to the more appropriate person when it comes down to it. You can't just try and do everything on your own. If you've ever been a homeowner and you tried to DIY yourself through a bathroom remodel or redo plumbing or electrical, I'm sure you've been through some type of scenario where you ran into issues and you probably had to call somebody else to come and help you. Don't do that with someone's body. Don't do that with somebody else who is relying on you to be the professional in that. Sometimes the most important part about being a professional is understanding that it's outside of your professional scope.
Newsflash. I have referred people out to get surgery. I have also referred people out to get medications and injections. I really have. Minority, but it's happened, right? So I think you're absolutely right. But I think coming back to the pain point, and we always preach this, right? Train success. If you have someone that's in pain, the first thing you need to do is identify what they can do that doesn't freaking hurt. Because if you don't do that, you literally cannot write a program for them. Like every time they come in, it's going to be guesswork. It's going to be probably more frustrating for you maybe than for them, because you're literally just going to throw shit at the wall and hope something sticks. And again, I think it's such a simple thing to carry out. Do some sort of, we call it our plan smarter strategy session. I don't really care what you call it. Do some sort of big body, full body, patterning, assessment, whatever word you want to say, but get some information on that first visit or two with that client, because then you can program for them. And all of a sudden it takes you from having to redo everything every time they come in the door to already having a game plan, because that Bob can squat to 18.5 inches with a bar on his back without his knee hurting. But every time he goes to 18, he has to limp out of your facility. Like if I didn't do that and get that information, I'm not going to know to program. So I think that is a really big aspect that is missed by a lot of people in this industry.
Yeah, 100%. I was going to say, to reference it back, I wrote an article for Tony Gentlecore's site. I want to say like 5 years ago, maybe. And the title was Sport Specific versus Sport Restrictive. And it was to challenge the mindset that we think there are these sport specific exercises, when really what I think people should be doing is identifying what are the movements that are not advantageous for that person. And as an athlete, do everything else. And I think it's the same thing when we talk about people with pain. It's not a matter of being like, okay, well, you have this kind of pain, so we can only do X, Y, and Z. It's no, you have this pain, so we can't do this and this, but we can do everything else. And I think it's a matter of looking at the glass half full versus glass empty. Don't find all the things that are not good. Find the things that you can do. It's the same thing with diet. Like people tend to get be unsuccessful with their dieting pursuits because they think of all the things they're cutting out instead of thinking of all the things that you can add in. So I think as a coach, it's your job to do that and identify what are the things you can truly get really strong at. Because specifically with the certification, that's the first question I ask when we go through the squat pyramid is I ask everyone, I go, okay, well, can you get strong with all of these exercises? And everyone's like, well, yeah. And my next response is, well, then why the fuck does it matter which one you do? Like, why does it, it's not, there's no superiority to this where it's like, oh, well, this one's the creme de la creme. It's like adorable, but like, what are they all going to get you strong? Cool. Go with the one that makes the most sense for you then. Like, you don't have to battle this and go, well, you don't back squat. So, you're not going to be super strong. Fuck that. Most people aren't front squatting. Most people aren't doing double rack squats. Most people aren't doing safety bars. Most people aren't box squatting. Most people aren't adding accommodating resistance. A lot of people aren't doing variety. So what can you do that's in there instead of focusing on what you can't have? Don't focus on what you're allergic to. Focus on the things that you can still have.
Amen to that, dude. And again, I think it's a simple concept that goes a long way, but I think a simple concept that's really forgotten. It's one of those things, if you do the simple shit well, as a coach, as a trainer, people are going to feel really good. They're going to get stronger and they're going to keep coming to see you, which is really the ultimate goal.
Totally. So what I would say is, because I know we discussed this a little bit when we had the PT roundtable, but two of the areas that we tend to have the most issues with tend to be the shoulder and the lower back. So I want to ask you a little more specifically with regards to these scenarios, just giving me some quick do's and don'ts for some of the coaches out there when it comes to that. If you have somebody that comes in presenting shoulder pain, which is a very widescaping, could be a bunch of things scenario, what would be your initial advice for coaches out there if they have clients that are starting to feel that type, any kind of shoulder pain? What should be their initial steps to navigating that?
So the initial stuff with shoulder pain, I think some good workarounds. And again, like with you, there's so many different types of shoulder pain. Like there are 7 different types of subacromial impingement. And then there are people that are saying that's not even really a thing. So fine, just general shoulder pain. The things we'll find that are pretty successful in shoulder pain. Number 1, stop pressing overhead. It is probably the number one rule when people have shoulder pain. Shoulder pain tends to be on the front or the side of the shoulder. All right. A lot of times, repetitive overhead pressing will piss that off. You're not breaking their shoulder, but it's like if you've got a sunburn and you put hot water on a sunburn, that fucking hurts. The hot water is not making the sunburn worse. It just irritates the sunburn. The sunburn is the cause of you having an issue, right? So pressing overhead is like putting hot water on a sunburn. Just like let that stuff calm down. And I think the other biggest piece is, yes, run them through that shoulder scour test. So we want to identify where is their elbow supposed to be in relation to their body on any pull and really any push. That's going to be really goal number one. You know, it's funny. I just had a online patient of mine. I just saw her one time. She's doing awesome now, but she had 2 years of shoulder pain. And diving in a little bit, she does a lot of group fitness. So it's a lot of push-ups, burpees, TRX rows, things like that. And I looked at how she did all of her shoulder work. And every single thing she did was her elbow almost directly against her body. So when she went into a attempt to retract her shoulder blades, there was nowhere for her shoulder blades to go. Her humerus would tip forward, and she actually had a biceps tendonitis for about the last 2 years. And it was funny, in her little assessment I did with her, we had her do some push-ups, took her elbows out a little bit wider, and she did push-ups. And, you know, again, this makes me look good, but it's just a simple thing. She's like, hey, my shoulder doesn't hurt doing a push-up for the first time in 2 years, and I can actually feel my back in a push-up. Like, that's the goal. So when it comes to correcting push issues, again, general sense, do a ton of pulling. Do a ton of pulling at all angles. Make sure their shoulder blades move, though. You'll have so many people that almost try to lock down how their shoulder blades are. They almost pull them into retraction, and then they start moving their elbows. And it's like, your shoulder is already at the end range. You got nowhere else to go, which means you will compensate through the actual glenohumeral joint itself. You'll hit some soft tissue, and it's going to get pretty angry. So those are really like pretty basic things. And I know in my career, I've corrected and I think helped a lot of people that had shoulder pain by doing not that much pushing, doing a ton of pulling. And then when they were good with pulling, meaning they could feel their shoulder blades, we could load it up, we went back to pushing, and pushing was much more successful. And starting really with something like a push-up. In my practice, I really like the elevated push-up as one of the easiest ways to get back into doing pushing exercises. Mm-hmm. I will use the landmine a lot as well, not so much to build strength, because if we're being honest, you're probably not going to build a ton of pushing strength with the landmine, but it becomes a way for people to get more confident and being able to just get more volume of pushing without having to force feed like an overhead press. Sure. And then eventually we'll get to dumbbell, maybe a slight incline bench, and eventually maybe a neutral grip type of deal. But the last thing I ever have people do is a barbell bench press or a military overhead press to try to fix their shoulder pain. Again, I think there are a lot of aspects we can do. I think there are a lot of sexy things that you'll see where people are using kettlebells in all different positions. And I like that. I like the bottoms up press. I like the bottoms up holds. I like all that. But that's really just teaching irradiation. That's teaching someone how to get tight. Again, I don't find so much that we're creating true strength with just using unstable bars and unstable surfaces. At some point, a lot of times correcting the shoulder issue will truly come from teaching them how to use their freaking mid and upper back and loading up fairly heavy mid and upper back work, and then eventually rebuilding in shoulder pressing type of deals and movements.
Yeah. Listen, totally. First and foremost, I have to address it. You bashing the barbell bench press, it's not something I'm going to stand here and just listen to. Okay. I'm not going to sit here and listen to it. I get it. I understand it. It's not ideal for most people. I do, majority dumbbell bench press with a lot of my stuff. I do more supinated dumbbell now. I kind of got away from the
you barbell bench press 5 times a week. I know
wish.
You do.
I wish. My shoulders won't allow me to do that, but I wish. But yeah, I've gone towards more dumbbells over the years, and then I'll spice in a barbell every once in a while. But I think that's a perfect way to look at it. There's a couple notes I put down. Number one, for a lot of people when it comes to pain, like you mentioned, like the big rock is the easiest thing to get out of the way. And we don't look at the big rocks. So number one is there are 2 main things that people can have wrong on why they feel pain before we assume that they're broken. Number one is setup, and number 2 is execution. If someone's in the wrong setup, then you're most likely not going to perform the exercise with the best form possible. And the execution is going to derive whether you have extra pain or extra stress in areas that shouldn't be, managing those. Main thing, muscles manage stress. Joints shouldn't be managing stress. Muscles produce the force. Joints shouldn't be absorbing and producing the force. They will in small iterations, right? Like they'll absorb some force if you're doing ground foot contact in a gait pattern, but they're not meant to absorb that. It's the muscles that are meant to absorb that. So what I would say is, as a coach, go back to someone's specific setup and their execution, and that generally will give you an idea of what the hell is going on. And if you're unsure of what you're looking for, then find someone or go to the PPSC certification and figure out what you actually should be looking for. Number two, to your point, is it's good for people to work vertical-ish, not necessarily vertical. I think that we overvalue someone's ability to shoulder press X amount of weight. And, I can't remember the last time I've had to press 150 pounds overhead in my everyday life, because it doesn't happen. So why are we always training to try and get stronger through that lift? Well, because the lift looks cool. Awesome. And then, you'll be paying the lease payments on your shoulder issues for the rest of your life because you wanted to look cool for that one moment in time. So take that into consideration, that I do enjoy vertical-ish things. I agree with you. The landmine will only get you so far, but it's great for helping to teach mechanics of something in a controlled manner that's at an angle that's not true vertical, to help get someone a little bit of that confidence in pressing overhead-ish to ideally put them in a better situation. But yeah, going back to modality, going back to setup, execution of what someone's looking to do, you're going to find a lot of scenarios that can really put someone in a better position if you just troubleshoot some of those easy, basic things first and foremost. And then again, I think the important thing to talk about for pushing versus pushing is going to be a little more damaging for somebody than pulling, and put you in a more vulnerable position than pulling. And here's one of the main reasons why. When you push, you are moving towards a bone stacking mechanism, and you're generally at a mechanical advantage when moving through that pattern. When you go through a pulling pattern, you are moving into a mechanical disadvantage to that pattern, with the dead spot and the most vulnerable position being the end range. So what happens is when you get fatigued, tired, sore, if you're using weight that's a little more intense than you thought, when you're going through the eccentric or the downward of a dumbbell bench press, for example, it's much easier for the weight to push you through the wrong pattern or the wrong track, because the weight is dictating where you move, not necessarily you dictating where you move. And in a fatigue scenario, you're more likely to get thrown into the wrong track than you are through a pull, because of the pull, you just won't be able to pull it anymore. You're not going to pull yourself into the wrong direction. You're much more likely to, in a push, let the weight pull you through the wrong direction during that eccentric. So that's why we're very adamant on that kind of stuff. Like, pulling is much safer than pushing long-term. And you don't have to do a bunch of vertical stuff or barbell bound exercises in order to build capacity within the deltoids, the shoulder, or your pushing patterns overall.
And the thing I think that's interesting, I mean, the one thing that blows my mind is people's inability to move their shoulder blades on their freaking rib cage. Like, number one, it's probably the biggest rock that's going to help correct shoulder problems.
Yeah, but how many bodybuilding forums are telling you to pack your shoulder blades and that's going to maximize latissimus dorsi activation? Like, we kind of do it to ourselves too.
Yeah, no, you're absolutely right. It's one of those things. Your general fitness clientele, your general health person, like, it's amazing to me how many people can't move their shoulder blades on their rib cage. Just amazing. And one of the easiest ways to help correct shoulder is you actually just teach them how to do that, and all of a sudden every pull becomes more effective. But the other thing I do like about shoulders and rehabby type stuff, closed chain activities. So I really do enjoy closed chain shoulder work, especially when that person wants to do, more overhead stuff, but they can't. And let's be honest, I mean, pushing is, like you said, because you're stacking a joint, it's much more compressive on the body than a pull is. But getting in a closed chain position, that could be planks, that could be side planks, that could be things on your back, maybe with the kettlebell working, which I guess isn't technically closed chain, but it's still driving that weight through the shoulder. But closed chain based activities, crawling, I think all of those things are really other great aspects to teach good shoulder health, good shoulder positioning. That don't get appreciated for what they are. I think a lot of times we just do planks as a finisher. It's like, well, no, planks are actually a good way to really teach serratus work for people, which is another probably forgotten muscle of the shoulder. It's a really good position to teach people how not to dump into their shoulder blades. Yes, it's going to get your core, your pillar, full body irradiation, and all those pieces, but especially a side plank position with movement becomes a really excellent way to teach, I think, good habits for long-term shoulder health.
100%. But that's such an important thing is looking at the shoulder from the full perspective of what it can do. And again, just be more cautious when you're working with somebody within that, so you're not doing crazy stuff within their programming. So let's now bring it to the lower back, because I deal with lower back pain. So I want to hear you voila me with some really cool stuff with the lower back. But lower back pain is one of the more prominent things that we'll see people with. About 80% of people are going to see an incidence of low back pain at some point in their life. About 30% of people live with chronic back pain. Can you go a little bit into low back pain and kind of what are some of the more common causes that you see or have seen anecdotally in your practicing? And then we'll go over what are some easy protocols to kind of help people out.
So low back pain is really tough. Again, you said it, 80% of Americans will have a debilitating episode of low back pain in their life. And I think when it comes to the medical aspect of this, it's one of the areas we're horrible at treating because there's so many things in there. I mean, you have your spinal cord goes through your back and all the nerves for your lower limb go through your back. When it comes to low back pain, a couple of things that we'll try to dive in on the clinical end. Is this a neurological issue? That's one of the big things that we'll always look at, right? So if someone has loss of sensation in their foot and they have weakness of their ankle, well, that's not someone that I'm going to work out hard at the gym. That's probably potentially going to be referral into a clinician at that point and maybe even a spine physician. But very commonly with low back, I think the low back is like pain itself. It's so multifactorial on possibilities. And it has to be context specific. So for example, when I say about that, if you think about a golfer, okay, so you have someone that does a predominantly rotational sport, they have to have really excellent internal and external rotation of their hips, of their tibia on their femur. They have to be able to in and evert their ankle, and their T-spine better be able to freaking move, and they should be able to control all of that. However, all of a sudden their back hurts, and we have to ask ourselves, if it hurts in a golf swing, then why don't we find potentially the areas that aren't doing their job and cause you to feel a little bit more in your low back, which again, could potentially be all those body structures I just mentioned. There's this idea of regional interdependence, right? Your knee bone's connected to your thigh bone, that whole song, right? There is this idea that things can happen through the chain, right? I've just found the farther away you get from that area that hurts, you have to be able to have a much more concrete thought process and actually connecting those things. But again, when it comes to back pain, we start with a context specific reason why, like what activity does it hurt during? So you'll see hip mobility have a role. You'll potentially see ankle mobility and specifically subtalar motion, especially in rotational things and sports, play a role. You will certainly see maybe, I think in medicine we use the word core weakness, and I hate that because there is a lot of evidence that suggests for non-specific mechanical low back pain, so it's not generalized to a spot and it specifically hurts every time they do the same thing, so non-specific mechanical low back pain, doing core specific exercise is just as good as doing general exercise. So like one doesn't make a difference, but I think for that person that has an issue at the bottom part of lifts, that has a hard time picking things up off the floor, it comes down to teaching them how to brace. I don't think it's so much your core is weak as, and maybe that's a little bit of it, core strength is a good thing, but more so becomes teaching them how to get tight in certain positions, because people don't freaking know how to get stiff, especially when they're going to lift heavy loads or even light loads. The other things that we'll tend to see, and this is why back pain becomes so multifactorial. So in female populations, you can have pelvic floor issues refer to the low back. So there are very specific questions I will always ask every female that comes through my doors about incontinence, about other maybe very personal things when it comes to pelvic floor health, because those things actually matter. Because if they check all those boxes, they actually shouldn't see me. They should see a pelvic floor health specialist.
Sure.
Other issues that can cause pain in the low back, well, shit, cancer, metastases. So again, it's not to scare people. Your kidneys are there, right? Very rare that you're going to have someone have a kidney issue that happens with the low back. But when it comes to a clinician, having a differential diagnosis ability is extremely important. I think when it comes to the strength coach perspective, when it comes to low back pain, most of the times what I see is, number one, people don't know how to brace. They don't know how to get tight. Number two, they go through a greater range of motion than they can control. And there wasn't a graded exposure to it. So I think this could be a little fun conversation. Training direct spinal flexion. I didn't really want to go down this hole, but we're going to go down this hole.
Let's do it. Let's dive in.
So I think there's a lot of different thought processes and a bunch of different camps on, should we train directly loaded spinal flexion? There's one camp that'll say yes, and there's one camp that'll say absolutely not. If you look at, a certain physician PhD's work, you're going to see repetitive flexion to the spine is going to cause some sort of damage to the intervertebral disc in the spine itself, right? I think there's certainly a possibility, and I think it's not just flexion, but I think it's any position. The evidence is actually pointing a little bit more towards spinal flexion being safe when done appropriately with graded exposure. It's the same thing. I actually made a little post on Instagram yesterday about spine flexion and loading and actually helping heal discs over the course of time versus inactivity makes your discs worse. It's the same idea that a lot of things are safe. It's just the person wasn't ready for that when we asked them to do it. And that's why they got hurt, right? So it's not the load that breaks you down. It's the one you're not prepared for. But I have seen people that I have trained some direct spinal flexion, gradually graded exposure over time. And that was the thing that helped clear up their low back. I've had people that flexion was horrible. So we did a bunch of spine extension. We did reverse hypers. We did glute bridges. We did a bunch of local low back, glute and hamstring work. And that was the thing that brought them up. So I think there is also that aspect that having weakness of the low back musculature could certainly play a role with people that have back pain. But even just sitting here hearing me talk about all this, back pain is such a multifactorial issue. And me spouting off all that information is just like, fuck, there's a lot that can go on there.
That's good, though. I think that's the whole purpose of me asking that is like, it could be degenerative disc. It could be blunt force trauma within the actual vertebrae. Like it could be from you sitting in bad positions long-term. It could be you deadlifting like an asshole. It could be a lot of things, right? But I think that's important to discuss because that is where a lot of these things happen. And I think for the most part, from things that we do, a lot of this low back pain that we deal with can be avoidable. And when I say that, I mean like some of the degenerative things, maybe we're doing certain tasks that are not advantageous for that, right? If you're swinging like Happy fucking Gilmore and you don't have the necessary thoracic rotation, you don't have the internal rotation of your femur, external from the opposite side, tibial rotation to brace, and the ability to put your feet in the right fucking position, then yeah, it's going to hit the midpoint, which is going to be your back, which is the low end point. Another one of the reasons that we have low back pain, which listen, I'm going to say it and it's going to be, I'm sorry that I'm going to disrupt some people, but if you're fucking overweight, you're going to be dealing with low back pain, right? Like if you weigh more than what your skeletal structure should manage, the low back and the pelvic area is that midpoint within the chain. And if you have that where it's trying to manage everything, your core stabilization has to stabilize even more for you carrying around essentially a backpack all day. Right. And that's only considering that you are 30 pounds overweight. So I think that's one of those analogies that you tell for people, right? Especially, I remember I've had clients that maybe they wanted to lose, 20, 30 pounds. And they're like, yeah, it's dragging on me. And I'm like, well, how old's your kid? They're like, oh, he's 3 years old. It's like, okay. Can you imagine carrying your kid around hanging off your stomach all day? That's essentially what you're doing. Right? That's not going to put you in an advantageous position. That's also going to change the way that you sleep. How you sleep is going to manage how much stress is on your lower back. If you're in a poor position, if your pillow is shit, if your mattress is shit, like that all comes into play, right? So to your point, it's very multifaceted. There's a lot of things that are involved, but we run into low back pain so frequently because it is a frequently accessed area. And it's a center point for a lot of these things. I tell a lot of people at the courses that pain derives from the center out. if you aren't bracing properly, the first two areas it's going to affect is going to be your shoulders and it's going to be your lower back. That's where it bleeds. So if you aren't able to brace and pick things up, then yeah, you're going to have a hard time doing that. I'm glad you brought up spinal flexion too, because we will live on the pendulum where it's like the spinal flexion is fucking great. You're going to build great abs, or it's absolutely horrible for you. You're going to shatter your spine the first time you do it. And it's really neither of them. I think if you want to build some aesthetics, you need to know that you don't need a 135-pound barbell on your chest to do sit-ups. That's probably not necessary for you. But you have to sit up every single day too. So that's no different from the person that says, oh, well, you shouldn't be squatting because squatting's bad for you. Okay, well, try going to the bathroom. Like, try getting out of bed every morning. Enjoy that. If you want to get out of bed every morning, you got to sit up. Spinal flexion is necessary. You want to pick shit off with the floor, you got to flex your spine. So like, you're going to want to have some capacity at it. It just doesn't mean you have to go all the way to it. I think we are a society where we know the boundaries and we like to toe the line. And that is unfortunately where we get into most trouble.
Yeah, as one of my professors in grad school said, a healthy spine moves in all directions without pain. It was made to freaking flex, right? Again, I think the biggest thing with back pain is identifying the agonies is what pisses it off and what doesn't for that client coming in. And from a clinical end, it's figuring out where it's coming from first. Once we can kind of, on a clinical side of things, identify the area of potential issue, it becomes a lot easier to treat because people will have movement biases. They'll have it as a referral from another body area, right? It doesn't become an easy thing. But like you said, definitely something I deal with it. Freaking hurt my back probably 5 or 6 years ago. I mean, if you've ever deadlifted for more than 10 or 15 years, you probably hurt your back. So sure. Definitely an area that we deal with a lot.
Yeah. And I think it's important to also understand the evolutionary implications that we've had, right? We began as quadrupedal animals, and the quadrupedal spine is very different from a bipedal spine. So we had to create these lordotic and kyphotic curves to accommodate us standing upright, which has created the lumbar spine to become a little thicker in vertebrae and absorb more of the force necessary from us stacking. And then we do movements such as back squats, where we are now placing a heavy bar on top of the spine to try and hold that in position as well. And to your point, if you can't brace, you're going to have a really hard time doing that. So I think we tend to get a little further down the line than we are okay with. And again, it's about, are you challenging yourself with things that are difficult and not eliciting pain? You could do a heavy ass goblet squat. You ever want to do John's half body weight, 25 reps? Don't tell me that's not tough. That's a fun time, but you're not going to be putting the same demand on your spine. There's not as much axial loading. So choose things that are probably more appropriate, right?
Yeah, axially loading with speed with load is probably not a great idea when you're not ready for it. That's what I think of when I think of spine flexion, right? Spine flexion with velocity and heavy load, you're not ready for, not a great idea. But again, if you look at a lot of the, strongest freaking people in the world, you're sure as hell flexing your spine when you're going to deadlift that 5 to 6 to 7 to 800 pounds. You don't have a perfectly neutral spine. There are mechanical studies that will discuss and basically state any deadlift has spinal flexion. There's really no such thing as neutral spine. But the more we can promote an extension position as we're going down to deadlift, will potentially just be more protective of those areas. That's how I tend to look at it.
Yeah,
and what I think works well.
And I love that. And I think going back to the original definition to wrap it up is like, it is a pain, it's a sensory, and it's an emotional response. If you think that your back bending is going to elicit pain, it's going to create that issue, then it might be a self-fulfilling prophecy at a certain extent. Like, it might be one of those things where you see that and you're like, oh my God, like, listen, your back bending, yes, it shouldn't fold in half. When you're deadlifting, you shouldn't see someone completely collapse at the mid back or low back. But a little bit of movement isn't the end of the world. That's okay. Can you manage that brace when going through there? So we need to do a better job of not instilling fear in everyone when it comes to being potentially painful, and start instilling and inspiring people to be more confident within the gym and take smaller strides and not let the ego drive the session.
100%. And I think, again, finishing up, understanding, we could talk about the actual pain signal for a very, very long time. But just understanding when it comes to pain, bring this back around, pain is very multifactorial. It is not only based on the input coming in, but also it's an output really from your head, from your brain. You know, to give an example, there's a couple studies that'll talk about setting the expectation verbally. So they gave two groups of people the same painful input, but if you were told this is going to hurt, you significantly reported more pain than if you were told this is going to feel fine, even though it's the same input. So again, just understanding even how we talk to people, that person's mood, the amount of sleep that person has had, the amount of stress that they're under, that all of those will 100% play into that person's individual experience with pain in that day. And we just have to understand that. And again, we could spend we can talk about pain theories. We can talk about central sensitization. Why do people still have pain? What is
super
phantom limb
complex
pain? Right? We don't have time for that, but I'd love to talk about that one day. But understanding that really it is complex. Pain is an output based on an input, but really is an output from your brain. And really, we don't want to train people through a pain response. That is certainly not going to be an appropriate thing for anybody.
100%. Yeah, it's funny you mentioning how it can be kind of self-fulfilling when people tell you something's going to bother you. I'm getting all that now, where everyone's like, get ready when the baby's here. You're not going to sleep at all. Your life is over. And I go, well, it's not going to be over. I'm still going to get some sleep. I think I'll be okay, right? That fear factor of like, oh my God, you're in for it. It's like, maybe you were in for it. I think I'll be okay.
That's why you gave me that look. Because I literally told you that same thing like about an hour ago.
Yeah.
Here's how I describe parenthood. Early parenthood. It's awesome. It's the best thing you're ever going to do. It's also the hardest thing you're ever going to do. But you could always take a nap. If someone asked you on a Wednesday at 1 p.m., Dave, are you tired today? You're like, could you take a nap right now? You'd go, yeah, actually, I could probably take a nap right now. It could be 8 a.m. on a Thursday. Ask the same question. Yeah, I'm a little tired. I could probably take a nap right now. That's what being a new parent feels like.
I love that. Listen, I don't take naps very often, so I wouldn't mind a nap or two. I'll be honest. Listen, man, I appreciate you coming on and talking some pain, especially getting into some of the specificity of these joints. Listen, let's be very clear with this, guys. These joints are very, very detailed. There's a lot of subtlety that goes into it. So it's not a, hey, shoulder pain, it's this. Like, no, there's a lot that goes into it, but that's why you have to know what you can navigate and what you can't navigate. But as always, we have new episodes every single week with the Pain Free Performance Podcast. We have new articles every week. If you aren't following us on Instagram, you are doing a disservice to yourself. We are at Pain Free Training on IG. If you aren't following at Dr. Justin Farnsworth, if you want to see some bearded masculinity, heavy lifting, thick muscles, and kind of fluffy hair, I think Justin has enough hair on his head to accommodate for myself and Cliff and John. Maybe not John, but myself and Cliff. Listen, follow him. It's a good follow. I appreciate you, buddy, and thanks for taking the time.
Thanks, Dave. Appreciate it.
All right, everyone in the community, as always, stay strong. Later.